Good morning, everyone. Thank you very much, Tess, for the kind introduction, and thank you, Albert, too. And welcome to the people, well, everyone, but people from Scotland. I'm from Glasgow, not Newcastle, but I did spend some time in Newcastle, and I've not lost my Glasgow accent, so I hope you can understand me okay. And I'll try and speak quite slowly, because we Scots tend to go quite fast. Badri's just arrived, actually. Our very eminent surgeon, Mr. Shrestha. So just to begin, so I've been asked to talk about ADPKD and me, the basics. And this is what I thought I'd try to cover during this time. So what is autosomal dominant polycystic kidney disease? How did I get it? How is it diagnosed? What symptoms or problems may I develop? And I appreciate that's very personal and very individual, but I'll try to cover some of the main symptoms that people tell me about. How will I be monitored? What treatments are available? And just finally, because it's a familial condition which runs in families, what do I need to think about my family and how will they be checked? And just really before I proceed, I just wanted to say that during the presentation, I'll show a few slides with some pictures of some quite enlarged cystic kidneys. I don't want to cause any concern from that. I'm sure most people, when they're first diagnosed, often Google or look to some sort of online browser, what is ADPKD, and you often see some quite frightening pictures. So I don't want to recapitulate that today, but just to warn you that there will be a few pictures, and usually it's the more severe end of the spectrum of some of the pictures I'll be showing, okay? And most of the management I'm talking about today is about adults, okay? So if you're thinking about children, they're usually looked after until about the age of 16 by childhood kidney doctors rather than us as adult kidney doctors. So just some of the specifics are a little bit different, okay? Right. So what is autosomal dominant polycystic kidney disease? Well, it's the commonest inherited kidney condition and it runs in families. And it's thought that around 1 in 1,000, possibly 1 in 2,500 within the UK are affected. And that could be up to around 70,000 people. But that number may not be quite right. Sometimes people don't know they have it. And so there's various reasons why there could be more people or less people. And it's defined as the progressive sort of gradual development over very many years of cysts, which that likes bothering things, but so I didn't actually ask which the pointer is. That was a bit silly. Oh dear. Sorry about that. Okay. Sorry, I was looking for the pointer. Forgive me, please. Forgive me online. My napkins, this is why you're here. Tests well worth the money. Sorry. Where's the pointer? The one in the middle? In the middle? That one? Yeah. Sorry about that. Okay, so it's this is a normal kidney, which in terms of size is 10 to 12 centimetres, okay? And over time, if you have this condition, you will gradually develop these cysts, which are little fluid-filled pockets or little balloons of fluid, which over time can either increase in size and they tend to stretch the kidney, and they can develop anywhere in either kidney, okay? And over very many years, they can become really quite enlarged. So people who have got much more advanced kidney impairment can end up with kidneys that are 20 to 25 centimetres, so really, very big. And in 50% of people who are affected, by the age of 55 to 60, you may develop kidney failure. So this will not happen to everybody, but just to say that in up to 50% of people, so 1 in 2 with the condition could eventually, by sort of late age of working life, say, develop kidney failure. But this is very variable. And I really want to emphasise that because even within families with the same faulty gene that's caused the condition, so the same error in your genetic makeup, it's very variable. So just because your mum or dad has developed kidney failure by a certain age does not mean that that will happen to you too, okay? In part because we've now got some other treatments available that may not have been available then. And some colleagues will talk about that a bit later, but also in part because we now focus very much on blood pressure control and other things to try to sort of slow down rates of progression, okay? It's more than a kidney condition, although most people are looked after by kidney doctors, okay? So cysts can develop in other organs in the body, and the liver is really the most common. And about 80% of people will have at least one liver cyst. And the number you have, again, is very variable. It doesn't matter whether the faulty gene is PKD1 or PKD2, that doesn't seem to influence it, except to say that people that might have PKD1 might develop things a bit earlier, okay? It tends to cause cysts throughout the liver, okay? Sometimes women are a bit more affected than men, and that's meant to be down to the hormone estrogen, or if you've got various pregnancies and things, that seems to play a role. But we unfortunately do see some men who are quite affected by cysts in their liver too, okay? It doesn't cause liver failure the way that it can cause kidney failure, but the main effect seems to be a sort of bloated or a bulk effect of cysts within the liver. I'll talk a bit later when I talk about symptoms, what sort of symptoms that might cause. It can, so PKD can be associated with cardiovascular disease, and by that I mean either problems with the heart in terms of heart attacks, or possibly with strokes, and some of that is down to blood pressure, okay? And we know that blood pressure control is so important. And not common, but around 1 in 10 people with the condition may have a swollen blood vessel in the brain or an aneurysm, okay? It's not common that we look for it in everybody that is affected, but if someone else in your family who's got the condition, so if mum or dad has had an aneurysm, then we usually would suggest that we do a scan to have a look for it, okay? So how did I get ADPKD? Well, usually in most people, it's inherited by a faulty gene in either mum or dad, so someone who's affected with the condition. Jackie is much more eloquent at explaining this, and she will follow me. But just to cover a little bit at the beginning, so basic level, we all have 2 copies of every gene, and the gene tells our body how to develop and grow as normal. So we get 1 copy from mum and 1 copy from dad. And if either of your parents are affected with the condition, they will either pass on their healthy, normal copy, or by chance, they'll pass on their faulty copy, okay? And that's why it's called autosomal dominant. So both men and women have got the same chance. There's no preference to whether boys or girls are affected. And it's a 1 in 2, 50-50 chance, because it's either the good copy or the bad copy that gets passed on. Okay. The commonest faulty genes for a very many number of years was thought to be only 2, and it was either PKD1, which tends to occur in most people who are affected, so 78, 80%. And there's different types of faults. So some are a bit more, I guess aggressive might be the right word for it. They cause the condition to behave in a more severe way and cause more symptoms and more problems than the other, okay? So you can have a PKD1 gene with a fault that causes you less problems than some other people. It's a different type of fault. And Jackie might touch on that too. PKD2 is the other gene that's usually identified as a cause, and that happens in around sort of 15%. And then the remaining percentage are now down to what we call as new genes. So really for the last, gosh, it must be about 6 years, there's been a number of genes identified in families all around the world by researchers who were originally thought not to have an identified cause. And then because they've looked closely in the labs, they've identified, actually there is a fault in this different gene we didn't know about, okay? Now sometimes they behave differently. So people don't get the big stretched kidneys, okay? But it's something that's caused the condition within the family, okay? So I hope that's not a bit clear as mud, but just to sort of explain some basics about the genetics, the inheritance. But in every single family, someone is the first to be affected, okay? And sometimes, you can find out quite incidentally, just, having a scan for a different reason. Some people have found out in pregnancy because they're having scans of, for babies and things. So people can find out at different times of life. And that's usually just because of suddenly a spontaneous change in your genetic makeup when it's dividing and so on. Okay, so someone's always first. How is it diagnosed? So usually it's by an ultrasound, so the jelly ultrasound scan, which is a painless scan, takes around 20 minutes perhaps. Some people might find it uncomfortable, I guess if you've got bigger cysts that are painful. And what you'll see, if this, oh dear, I'm not very good at this. Apologies. Okay, so what you will see is these little fluid-filled pockets. So black is the cystic areas on the kidney, okay? And what we then get is a cyst count in the kidneys. And the diagnosis is based on what age you are when you have your scan and the number of cysts that you have, okay? And usually people have this done because they've got a known family history and they're checked to see if they're affected. Do you want to come and sit down or find a seat? You want to? You sure you're okay? Okay. Don't want you to fall asleep on the spot. Or because they've developed symptoms. So sometimes people have pain or past blood in their urine or something different to have a reason to have a scan. Sometimes, as I said, it's picked up incidentally, so you go into hospital, a lot more scans are done these days, and you have a scan for a different reason. Sometimes even a heart scan will pick up cysts in the kidneys. Okay. And then sometimes it's done because of genetic testing, either because a family member is looking possibly at a kidney transplant, and we did some work on that a number of years ago, or because there's a known risk within the family and it's identified in that way. And Jackie will probably explain a bit more about that. So what symptoms or problems might you develop? And this is very much a might, because I think it's a very personal condition and affects different people in different ways. So you might pass blood in your urine, and that's usually because a cyst might burst. So this sort of fluid-filled collection suddenly gets to a certain size and bursts. Or sometimes if you've had a bump or something like that, and you can burst. People tell me it can be very painful, usually quite short-lived, will resolve by itself within a couple of days, usually, the pain, and then that will settle down, okay? And what we usually always say, if it is prolonged, so say several days, or you're concerned, it's a big volume of blood that you've passed, to seek advice, to see one of your doctors, either your GP or to see your kidney doctor, okay? No one would ever be upset with you for asking for a review for that, because it is alarming, okay? You might pass large volumes of urine, and some people are up several times at night to pass urine, and that's because the kidneys don't concentrate urine the same as if they didn't have the kidney cysts. Sometimes you might get pain, generally in the tummy, or sometimes in the sort of the loin area at the backs, on the sides. High blood pressure, so it's a very common sort of early feature. Quite often children can have high blood pressure. So we must check for it, and it's important to know about it because it's very, very treatable, and we should work hard to treat it to try to avoid complications. You might develop an infection, so that's other things that can happen to cysts. Apart from bursting, you can develop an infection, and that could be an infection in a kidney cyst or in a liver cyst, or just in the urine itself. And sometimes your tummy can just feel very distended and swollen because you're having to fit these very enlarged kidneys or possibly enlarged liver within the normal tummy space. And I mentioned hernia, just thinking a little bit about what Badri might mention later, Mr. Shrestha, our surgeon, is that sometimes because the tummy is so stretched that you can develop these outpouchings or hernias sometimes. And sometimes if your job is a lifting or sort of quite a physical job, you might be more prone to that developing. Talk about the liver. So sometimes it's a sort of bulk effect. So if you have a lot of cysts in your liver, or sometimes where they are, it can cause you to have some heartburn or indigestion. You might feel full early after a meal, so you'll notice you can't eat as much. And sometimes partners can become a bit upset. I've cooked this beautiful dinner, why are you not eating it? And it can sometimes, once it's explained, people can understand a bit better. Sometimes people manage better by, or at least they tell me, by having small meals more regularly, just to sort of try to manage better. And some people can feel breathless, because normally when you breathe, your diaphragm, the big muscle in the tummy, moves down, and if there's bulky things there to prevent it moving down properly, people can feel a bit breathless because of cysts in the kidneys or liver. We might detect protein in your urine. It's not usually such a big problem in polycystic kidneys, but again, something we always try to target, because we know that protein in the urine is not good in terms of kidneys getting worse in terms of how they function. So we usually try to reduce that with certain medications. And kidney stones, so some people can be unlucky and have stones as well. And that's another reason obviously for pain or for possibly passing blood. And low mood. So I say this because I wouldn't underestimate how, I guess the gravity of just coming to terms with a condition like this. I think whenever it's diagnosed in life, so some people are very aware of it because they've seen a parent go through it, don't know if it's coming their way or not, and there's a lot of uncertainty, and sometimes with life choices and so on, or sometimes because you've got really difficult symptoms that aren't treated well. Someone got their hand up? Are you okay? No, okay. So I think just being aware that you could feel quite down in the dumps, and we very much recognise that. We don't have any magic treatments either, but sometimes just being able to talk about it is, I think, useful and helpful. And then just, I guess, kidney failure is important to talk about, because that's, what we are as kidney doctors, to try and help support you with that if it comes to that. To say it does tend to happen later in life. So if you've got a PKD1 gene and you've got a more severe defect in the gene, your risk of it happening is around 56, 58, 60 years, okay? And kidney failure usually is round about when the percentage kidney function, so this is 100 when it's all meant to be fine and good, down to around about 8 to 10% is about when you might need kidney replacement treatment, either dialysis or transplantation or something else to do the job of the kidneys, okay? But if you have PKD2, it might be much more like 80 years of age, or it may not happen at all. So you might plod through life having symptoms or not having symptoms, kidney function getting a bit worse, not reaching kidney failure, but we see you a few times a year, okay? So it is very variable, okay? If it does come that you're needing, the kidneys are not working, then once you get to less than about 20%, this is Sheffield I'm talking about, this is what we do, but I think it's probably quite standard across the country. Once you're less than 20%, we usually start making plans and asking how you feel about different dialysis options or transplant, okay? And we'll give you information and education to tell you what that is and what that means, okay? Okay, so how will I be monitored? So again, a bit back to what we do here in Sheffield. Traditionally, we always saw you excuse me, face-to-face in clinic. But since COVID, there's been a few changes, and obviously with trying to prevent people being at risk of catching infections and so on, now there's often an option for a telephone consultation, as long as we can check your blood pressure before your blood tests, and it's really helpful to be able to do a urine as well, okay? Some people can do that via their GP, and they're very supportive of that. Otherwise, we have the drive-through option, and most of you that are in Sheffield at least should be aware of that from letters coming out with your appointments. If there's any problems, excuse me, if there's any problems with any of that, please do approach one of us at the end and we'll make sure you know about the different options. Blood pressure, so again to sort of emphasise the importance of this, we always check your blood pressure, okay? And often we like to know if you've got it at home, a monitor, what you get at home, because sometimes no matter what, the stress of getting to clinic, getting parked at the Northern, it raises blood pressure, you know, for whatever reason. So your home blood pressure is a better, I guess, representation of what your blood pressure is like. And you're not with us most of the time. So if it's controlled when you're at home, away from us, that's fine, because you're usually not with us. We usually dip your urine, and if there's any signs of infection, we send for culture. And we usually do blood tests just to monitor your kidney function, and we usually keep an eye on your liver as well. And then in Sheffield, we tend to do an ultrasound of the kidneys around every 3 years. Okay, that was always our sort of standard. That's what Albert always recommended to do, and I think it's a good recommendation. If you've got symptoms, so if you suddenly feel you've got a lot of pain or something just doesn't seem quite right, or say you've had a particularly large cyst that we're watching, then we might do a scan more often. And some people will also have an MRI, so the more detailed scan. And there's a bit of a vogue for that quite a few years ago, looking at kidney volume, because that tends to change or increase earlier than the blood test dip. And I should have said that when I looked at the slide earlier, but usually the kidneys get bigger and then the kidneys stop compensating, and then the kidney blood tests get a bit worse. So sometimes the MRI gives a bit of an earlier reading of that, okay? The other reason you might have an MRI is if we're worried about possibly the risk of an aneurysm, so the swollen blood vessel in the brain, okay? And that's usually when you would have an MRI of your head, okay? So what treatment is available? Well, it tends to be quite personal. We ask you to report what symptoms you have, and we obviously look at your blood pressure and we try to make a plan from there. So there's medication, there's a whole variety of medicines to control blood pressure, and there's good evidence from different trials specific to patients with polycystic kidneys to show recommended treatments. Antibiotics, it's not usually a 3-day course for a urine infection, which is the standard for most urine infections. If you've got polycystic kidneys, you should usually have treatment for at least 7 days, sometimes 10 days, sometimes 2 weeks. Some of you will know this and you're nodding your heads, okay? But it's often just to be aware that you will need usually a bit longer, okay? Avoiding other insults. I think most people know, but the non-steroidal family of medicines, so ibuprofen, diclofenac, those sorts of drugs, and I appreciate, I don't want to be shot down by drug companies, but they put it on the box as well. So if you've got kidney problems, do not take these medicines. They are effective painkillers. I've taken them myself. They are helpful, but they come with a risk, okay? So if you've got kidney problems, I would not regularly take them, okay? Just very occasional if you feel you're in a lot of pain and you feel you've got nothing else to use. And again, speak to your doctor, speak to your GP, or speak to us to try and find an alternative, more suitable treatment for you. So pain, in that line, pain is difficult to treat. There's a study that's due to start next year. It's going to be an online study looking at pain and how it affects people, and we're hoping that that will help guide a bit better how we try to treat people. There's been a whole variety of things tried over the years, some surgical things, I'm sure, which are effective, but sometimes how long they last for is limited. So things like draining a cyst might give you benefit for a bit, but the chances are that cyst will recur. And that's why quite often the radiology doctors who do the drainage are not very keen for us to refer people all the time for cysts. And it's also not without some potential complications. Okay. And tolvaptan. So since 2012, 2013 was when the big international all around the world study was published, involving around 12 to 1400 patients. Really strong evidence that it worked both in slowing down the rate of kidney growth and reducing the rate of kidneys getting worse in terms of blood tests. And Matt will tell you a lot more about that a bit later on. But that's the only treatment that has really been proven to work so far. And you have to be eligible for it. And again, I'm sure Matt will cover this, but if you're, in some ways it's a double-edged sword. So to be eligible for it, you've got to be doing worse. Nobody wants to do worse, but you obviously want to be potentially available to have it. So I think it's that sort of balance, being aware, okay? Not an easy drug to take. We're lucky we've got a Sister McCormick who tries to offer a lot of support to our patients here in Sheffield. I think quite a few different units around the country also have a specialist nurse to try and offer support in that area. There's no cure, there's no genetic magic bullet, unfortunately. But if the kidneys are failing, and this is obviously specific to the kidneys, then we will plan for kidney replacement treatment or dialysis or transplantation. Okay, and then Mr. Shrestha will suggest other surgical benefits or things in that area which might help. And I think this is my last slide. So sort of thinking about your family. It's a familial condition. If there's in general health, so once you get to over the age of 50, they screen for bowel cancer, women get screened for breast cancer. So if there's a certain risk of something, it's worthwhile screening, especially if the test is simple and painless. So because there's a 1 in 2 chance that you might inherit this condition from an affected parent, screening is suggested. It's a very personal thing, whether people decide to take that on board or not, but they should at least be aware of the risk, okay? And you should have a discussion about what the implications of the test are. So, some people feel if they're diagnosed when they're 19, 20, they don't really want to know because it interferes with a lot of things. And what I would usually say to people like that is at least get your blood pressure checked, okay? If your blood pressure is fine, it doesn't mean that you've not got the condition, but at least the early features of it can be addressed, okay? And even if you're treated just for your blood pressure, but you don't want to have a scan, that's fine because we're looking at some of the medical complications that you can develop at that stage, okay? So you've got to have that information before the test. Ultrasound is sort of the main way that we screen families. And again, it's based on what age you are and what the cyst count is. We cannot exclude it before the age of 40. So sometimes people will say, oh, they've had a scan 25 or they've had a scan at 30, they don't have it. They may not have it then, which is great, but there's still a potential risk that they could develop it over time, okay? So you need to just make sure they've had an up-to-date scan at the appropriate age to try to rule in or rule out the condition, okay? And sometimes genetic testing or different means of testing can be more suitable in that case. And then just to mention again about the aneurysm in the brain. So if someone in your family's had one, we usually suggest that you should have a scan to check. Or alternatively, if you're in a very high-risk occupation, or if you've got symptoms, it's usually a reason to have a look. And I think that's me. So just a few thank yous. So thank you for listening, thank you for staying awake. Thank you very much to Tess and PKD Charity for coming to Sheffield, and we're delighted to be face-to-face again. And I've just put the PKD website on there just because it's a great resource with lots of information on it. And also thank you to Professor Wrong, who's been a colleague for a number of years now, for all his support and guidance, and also to Sister Janet McCormick, who I work closely with too. Thank you.
Hello? Does anybody have any questions? Yeah. We've got time. Yeah, okay. Thank you, Ros, for getting us off to a great start. Actually, you've got more. You left us with quite a bit of time, so got time for questions. So, are there any questions from the floor for Ros? And maybe those online might want to put it into the chat. So we have a lady here. Shall I?
You can get diclofenac cream. Is the cream okay?
The cream has still got a small percentage of the drug within it. So some people do use the cream. It's less damaging, but I think probably better to avoid overall. I suppose, and sometimes it depends how bad your symptoms are sometimes. And I think as long as you're aware Yeah, I think it is. Yeah, I think so. And it's quite a personal thing, isn't it? Yeah.
Any more questions from the floor? Yep, go on.
Me and my dad's both got PKD, but we're different because we haven't got cysts that are enlarged. We've got really tiny cysts. So what is the outcome for that?
So you've probably got one of the newer genes, so they tend to cause the kidneys not to enlarge, as I was saying earlier. So you're amongst the less common people, but still in a small percentage of families with that faulty change can still develop kidney failure, usually at a much later age, and often sometimes, depending on the exact faulty change, liver cysts can also be in effect. The genes, some of them were just identified really within the last 5 years, so we're still sort of learning, and it was usually in a handful of families around the world. So I think one was based on 5 to 7 families around the world, so we're still sort of learning, and I think some of the experience is still quite personal. But we'd still monitor your kidney function, and we usually find that they're less sort of damaging, say, or things are less aggressive than the more typical, more known about genes.
So I think Dr. Jackie will say a little bit more about some of the new genes that have been found, but yes.
I've got a question about the genes. I know there was two, PKD1 and PKD2. So my question is, if the mother got PKD1, will the kids could develop PKD2, or will the same gene is going to be passed in the whole family?
So usually what will happen is the same gene will be within the family, okay? The effects of that gene can be a bit different on the individual person, but you can only pass on what you have, okay? So if you've got PKD1, you can only either pass it on or not pass it on, okay? You can't suddenly pass on a different gene, okay? So.
Oh, right at the back, yeah. keep me warm. Run.
Okay, so I've got PKD2, but they said I've got a mutating gene that I carry, and my kidneys weigh 500 each. They're quite enlarged. I'm 54, but you were saying PKD2, maybe they wouldn't fail. That's what I'm worried about. Would they fail, or do I have a longer, even though they're quite large and I have a lot of cysts and stuff? So
That you've given, and again, it's probably best to go back to your own team to discuss in more detail, or if that's us, then we can discuss in more detail. So the volume, the size of 500 each, gives us information, and there's been some studies to show that based on the size and your age, we can then project roughly what we think will happen. Okay, so we can give you a progressive suggestion. Based on the gene itself, the studies that have looked at having PKD2, no matter what the change is, usually the average age of kidney failure is around 78. And that came from a big French group. So you should do better, but if it's a more aggressive faulty change, then sometimes you might do better, but again, it's all within a spectrum, within a range.
To my son, he has PKD1. He's much more aggressive in his, he's only 34, and he has much more problems than I do with his medical condition.
He's got PKD1 and you've got PKD2. The only other way that could, and again, I'll bow to Jackie, but the only other way I can think of that could happen is potentially if his dad had the condition and you didn't actually pass on faulty PKD2, and dad potentially had PKD1 and was affected and then passed it on. Pretty rare, or unlikely, I would say.
Because my dad had it and my granddad had it, my aunt had it, so it's definitely come from my side of the family. But yeah, okay, thank you.
I think Jackie will say a little bit more about the genetics, but yeah, thank you.
Hi, so it's just in terms of the kind of mutant gene. So you said that some families, it's never been present before. What kind of creates the mutant gene?
So, well, yeah, you do it better. I'll talk about cells dividing in your It's a good question, it's just not for me.
So if you look at any genetic condition that runs in families from one generation to another, if you go far enough back in time, you will find the first person. Is that better? Yeah, that's better. If you look at any genetic condition that runs in families from one generation to another, if you go far enough back in your family, you'll eventually find the first person. You may have to go back a few generations, or you may have to go back hundreds of years, but eventually there will be one person in which that condition has started. And how that happens is that when we pass our genes on, either through the egg or the sperm, you have to copy out a full set of genes to pass it on in a process called meiosis. And we now know that every time we do that, we incorporate changes within our genome. Now, most of those changes occur in the parts of the DNA in between the genes, so it doesn't really matter. But this is how evolution occurs. This is how things change over hundreds and hundreds and thousands of years, because of these changes that occur each time we pass our genes on. So if one of those changes that occurs when you're making an egg or a sperm cell happens within a gene, and it has a deleterious effect on that gene, so it affects the protein that gene makes, then that is the start. And we've estimated by looking between parents and children at their whole genomes, that every time we make an egg or a sperm, we incorporate about 5 or 6 mistakes. And it just depends where it is as to the effect of that.
Thank you, Jackie. We will keep more of the genetics questions till after Jackie's talk, but any non-genetic questions? Good, thank you.
Thank you. When I first was diagnosed with PKD, I was told, children-wise, that if they had scans when they were 30 and were clear, then they wouldn't have PKD. But I see in your board you're now saying 40. Can you explain a wee bit about that, please? Thank you.
So I think, yes, I should have probably have said that. So originally there was a suggestion around about 30, and that was thought for a number of years. And then there's been repeat imaging studies which have looked at age and looked at potential risk. And it's been suggested that to have a higher chance of excluding things, so studies call it a negative predictive effect, then it's at an older age, okay? There has been a few studies, again, a good 5-6 years ago, that looked at MRI. And because young people often is a little bit less certain, because to have the condition, you only need to have 3 cysts between both kidneys by the age of 40 to be affected. And you could have 1 cyst and not be affected. So to try and make that a more definite yes or no, then that was why the age limit was changed. I think probably the best yes-no is really from the genetic testing, but not every family we know the faulty cause. And I think that's improving with testing and with time, and again, Jackie may explain, but that could be the reason. I think the other thing to say is with MRI, there's then recommendations of the number of cysts that you're potentially allowed to have for MRI. And that partly came around because of looking at people wanting to be a donor for a parent and wanted to make sure they didn't obviously have the condition. So that's why a lot of that was looked at more closely.
Thank you. So maybe one last question. I just to kind of add to that, I think the original guidelines, you're absolutely right, were designed for people with PKD1. So that applies to 8 out of 10 people, those families. But the 2 out of 10, which are PKD2 and the others, the age cutoff doesn't apply to. So the age cutoff at 40 was to try to cover both PKD1 and PKD2. But now we know that the newer genes, the non-PKD1, PKD2, that doesn't apply either because they can be later. So it's changing. So you're right, absolutely, yeah. One last question, not on genetics, because we have a lot of genetics questions coming online. I think Jackie would be very busy, so I need to give her more time.
Detect cysts of a certain size, whereas MRI can detect much smaller cysts. And so people that have got a newer gene tend to have what we call microcysts, which on an ultrasound you may not see that many, but then when you do the MRI you can see lots of very tiny cysts, which in the past were thought perhaps not to be important, and now with more details, it's looking at that we can see that it's relevant and it's important.
In terms of children of someone with PKD, what age is sort of the recommendation for engaging and kind of undergoing those ultrasounds or whatever the tests are to see if they have got the condition? Thank you.
I think it's a really good question. I think it's a very hard question. I think it's a very personal question. Usually it sort of depends on whether you shared or you feel your child's at old enough age to be able to share your own issues. And I think then once they're aware of that and they've had a bit of time to understand that, it's then maybe, again, this is very personal, I think, and I think there's no right answer. But I think then when you feel able to discuss that with your child and then say there's actually potentially a chance that you could be affected. Now, different doctors are say different things. Expert opinion of paediatric, so child specialist doctors a number of years ago said that children, because of risks of blood pressure and things that could be treated, that they should have their blood pressure checked from the age of 5. Just to know and just to treat. And I think that's a lot for a child, but I'm an adult doctor, and so everyone's got slightly different opinions. Usually what I would say to people is when you feel able to share your own diagnosis, and then when you're able to sort of try to think about potential risks, often genetic doctors will be very happy to see families to potentially discuss. Sometimes children are incidentally flagged as potential concern at the time of birth, because that's when they've got a natural scan. And sometimes those cysts can disappear and go away, but again, childhood doctors would explain more. Otherwise, people often say when you're going away to university, it's a time of life changes and life choices before they have children themselves, just to make sure that they're aware of potential risks. So sometimes first ultrasound might be mid to late teens, blood pressure checks maybe early, but not diagnostic, just suggestive of there being an issue. That's very vague, but it's honest.